Welcome everyone to today's webinar. The webinar today is 2022 in Review, a research update. So we've got along Brett Drummond today from MStranslate. I'll be a facilitator. My name is Peter Butler. Very excited to get Brett along.
Thank you, Peter, and obviously thank you to MS Plus for having me along to discuss this webinar. Talking a little bit about MStranslate at the start, just because I understand that some of the people watching the webinar may not know who I am or know who MStranslate is. So just to give you a really quick background on that to gain an understanding of why I'm able to be here and talking to you about what's hot in multiple sclerosis research, and then really for the majority of the presentation going through some of the MS research updates from 2022, with a large focus on things that we heard at the recent ECTRIMS conference in Amsterdam. As Peter said, we're going to have a lot of time for questions throughout. I'm more than happy to answer questions as we go through. In terms of the MS research content, it'll be really broken down into topics, so there'll be opportunities at the end of each of those topics to answer questions. But also, if you have questions about general MS research related questions that you want to ask as well, please do, and I'll be happy to answer those at the end as well. Realistically, the main reason for me to be here is to give you information that's most important and most relevant to you. I hope the topics that I've chosen to talk about certainly do touch on things that are of interest to you and the MS community in general. But if there are other things, please do ask those as well. So just to give you a quick idea of who MStranslate is, obviously based on me being here, you understand that I'm part of it. But MStranslate was formed in 2012 by myself and my brother Eric, who is the other half of MStranslate. His background is web and social media, so he brings that aspect to it. Whereas my background is in multiple sclerosis research, which I did for many years, as well as science communication. And MStranslate came about really based on me having an understanding that while I was doing research, while I was at the research bench, there was this really large gap that existed between people doing multiple sclerosis research and people who were directly impacted by that research, people living with MS and the MS community in general. And so we wanted to find a way to bridge that gap, and I guess synergistically the skill set that Eric and I had worked really nicely to enable that to happen. So MStranslate was formed in late 2012. We've actually just celebrated our 10th birthday in October this year. And it's changed a lot over the last decade, but realistically it exists in two spaces. Space 2 is really what's going to be important and what I'm talking about today, but MStranslate works as a science communication consultancy company as well, where we provide our services to other organizations, biotech companies, or research institutes that may want to talk about their work. But primarily what we're interested in is MStranslate, the science communication initiative. And in a nutshell, what we do at MStranslate is provide updates on the most recent multiple sclerosis research in a way that is easily accessible, but really importantly, easy to understand and accurate. And we know that those last two things don't necessarily always go together. Researchers are great at talking about their work, but they're not great at making it easy to understand. Mainstream media is great at reporting about breakthroughs in medical research, but they don't always maintain the accuracy that's necessary. And so the fact that I have a background in both MS research and science communication means that we're able to keep that accuracy while making things easy to understand. And so MStranslate, in terms of where you can find us, just if you want to look at and see where we are on the web, we exist basically on all of your social media platforms, so you can find us in any place there. Really, you just need to search for MStranslate, make sure that it's all one word, capital MS, lowercase translate. Our website is where all of our unique content sits. Facebook is where we engage in a lot of conversations on our content, and YouTube is where you will see all of our video content that we produce. Twitter is particularly useful during conferences where we do live tweeting of conference coverage. So if you went back to the end of October, you would see all of the live tweets that we were doing during the ECTRIMS conference. So if you've got all of the slides, you'll be able to refer back to this to see where we're at. And so just to give you an idea as to what my day is like in terms of MStranslate, each of my days starts by opening 2 emails in my inbox. And I open them in a specific order. And so the first email that I open is a PubMed update email. So PubMed is a repository of all medical research publications that have come out. And so I get PubMed alerts each morning and with the keyword multiple sclerosis. So that updates me on any new research papers that have been published in the past 24 hours related to multiple sclerosis. The second email that I open is my Google Alerts email. And so that lets me know of any news stories that have appeared online, again, using the keyword multiple sclerosis. So any things that have been picked up by mainstream media or are getting a lot of attention on the web. You may have a bit of an understanding that I open one of those emails quite excitedly. And the second email, the Google Alerts email, I open with a little bit of apprehension because we never quite know what's going to be seen there. It's important that I open them in that order as well. And I'm just going to go through a couple of examples of why platforms like MStranslate are important. At this stage, I want to say as well that MStranslate is not a single resource for this sort of information. What's really important is that you find a number of different sites and resources where you can access high quality information and get ideas as to if you've seen things online, you know, is this accurate? Should I be believing it? We hope MStranslate may become one of those, but MS Plus is another fantastic source of information. MS Australia again, and there are other websites out there that also do a lot of good work. The problem is for all of the sites like ours that are doing good work, we hope are doing good work, there are lots of sites that aren't necessarily publishing the most accurate information, and that's what we need to be careful about. So as in just a couple of examples to explain, you know, why are we really passionate about having a resource like MStranslate? This was an article that gained a lot of online attention in 2018. So I'm just sharing one screenshot of one of the articles that was published, but this got attention across most mainstream media with the headline, "Doctors believe they've discovered the cause of multiple sclerosis." Now, you don't need to worry exactly about everything that's contained within that article, but if we just go through that first paragraph, a vaccine for avoiding multiple sclerosis has moved a step closer as doctors believe they have discovered the cause of the disease. Now, this had popped up in my Google Alerts, and so I mean, you would all have the understanding even better than me, but you know, if you're a person living with multiple sclerosis who for a very long time has been told that a cure for MS isn't going to be possible in the near future because we don't know what causes it, and it's going to be really difficult to find a cure until we know that, to read a headline that says doctors believe they've discovered the cause of multiple sclerosis is obviously going to generate a lot of excitement and a lot of hope. However, if you remember a few minutes ago, I said that I open my emails in a specific order. There is a reason why I do this. So luckily I'd read my PubMed updates before I saw all of these emails. And so I knew what research article this was referring to, and it was this one here. So again, you don't need to worry too much about all of what's contained within the abstract, but this was a hypothesis paper published by a number of researchers in the United Kingdom. Multiple sclerosis is caused by 3 hits, strictly in order, in genetically susceptible persons. Now, this sounds like a very reasonable scientific article. It's published in quite a good research journal, so we have a lot of confidence about what's in this publication. However, having gone through and read the publication, this was, as it says in the title, just a hypothesis paper. So this was 3 researchers who had sat down, read some of the literature that existed on multiple sclerosis that had been done by other people in other studies, and come up with a story essentially for how they thought those puzzle pieces might fit together. Now, while that has a lot of validity in terms of it's an important part of the scientific process, these researchers hadn't done anything to test this theory. They hadn't done any studies themselves. They hadn't gone in and looked to see whether or not their theory was correct, to see whether or not they could prove this in any way. They just put out their thoughts. Now, I think you would probably agree with me that there is a huge difference between putting out some thoughts that you've come up with while sitting down and reading a paper and the headline, doctors believe they've discovered the cause of multiple sclerosis. And so we need to be really careful when we see these things online, because unfortunately, these sort of sensational headlines that we see in mainstream media are all too common. I would love to say that this is an isolated incident, but unfortunately we see it, as I said, all of the time. So to go through another one just quickly. So this was another one. This was from 2015. So vitamin D could cut multiple sclerosis symptoms with the first lines. This was in the Australian, I believe, shared through. But again, this got a lot of attention in mainstream media. Taking hefty supplements of vitamin D could help to reverse some of the symptoms of multiple sclerosis, according to a study. Now, again, if we start by thinking about how this is going to be read by people in the MS community, vitamin D is something that's easy to obtain over the counter. This is suggesting that not only could it, help manage multiple sclerosis, but it's actually going to start to reverse some of the symptoms. And this has always been the big unmet need in MS, especially since we've got some of the newer treatments that are really effective at trying to slow the disease, but don't have anything that reverses it. So reading an article saying vitamin D, of all things, is going to be helpful to do that. It's obviously going to generate a lot of excitement. Again, I had read the article that this was referring to, and I'm going to share through the snapshot of a little bit of the article that we'd written on MStranslate about this study, which is this one here. So using the title, Effects of High-Dose Vitamin D in People with Multiple Sclerosis, some may say that the image that I've used choosing the chemical structure of vitamin D may not be quite as exciting as the one that the Australian chose to go with there. But, I think that the chemical structure of vitamin D is pretty exciting. But again, not going into too much detail here, but I can just run you really quickly through what the study actually showed. All that they had done in people living with multiple sclerosis is done a really short safety trial to see whether or not they could tolerate the high doses of vitamin D, which they found that they could. It was safe. That was it. They hadn't done any sort of clinical study beyond that. They hadn't looked at symptoms at all. Yet here we're saying that the vitamin D is going to reverse some of the symptoms of multiple sclerosis. It wasn't even looked at in the research project. All that they had done was they had looked in some cell culture, so getting some cells, growing them up in a lab, and then giving them some high-dose vitamin D into their little flasks. And what they found was when they did that, it shifted some of the immune cells that were present in that flask from ones that we know can cause some damage in multiple sclerosis to ones that are probably slightly more protective. But there is a big gap between doing that in a cell culture experiment in a lab and doing it in a clinical trial. And we know that a lot of the things that we see in laboratory settings, in early stage, even in animal models, don't end up working when we go through to clinical trials. So again, we need to be really careful about the sort of headlines that we're seeing there. So I think that's why MStranslate and other places are really important. And we think that at least at MStranslate, we do a good job because of the fact that I can go and read the research articles myself. I have an understanding of what I'm seeing in terms of the data and then can communicate that through, that we can sort of help to navigate a lot of the difficulties around information that appears online. So that's sort of MStranslate in a nutshell. Happy to take questions on MStranslate if there is any, but we're probably all mostly wanting to get into talking about the research. Peter, I don't know if anything's come through so far just on MStranslate as a platform. I think you're muted.
Yes, sorry. None about MStranslate itself. I just had a question come in about vitamin D. Webinars. So is there a relationship between vitamin D and sunshine with regards to sun heat intolerance? As I find I suffer from sunshine more than heat without actually burning or being fragile. I can feel it when a cloud passes by when I'm inside.
Good question. So there's definitely a relationship between UV exposure and vitamin D. So exposure to UV is one of the first steps in terms of producing it naturally in the body. So UV creates a precursor to vitamin D, and so that's an important part of it. And so that's why we know that, during winter months when we're less likely to get sun exposure or UV exposure, because we not only is there less hours of sunlight, but also we tend to be more covered up to protect ourselves from the cold. The vitamin D levels tend to dip across those winter months. In terms of a link between vitamin D and heat intolerance, that I'm not so sure of. I haven't really seen anything around that. There are probably different mechanisms at play around why people living with MS tend to struggle more in terms of heat or cold that aren't really directly related to vitamin D. Yep. All right, so that's the MStranslate part of it. Feel free if anyone has questions about that later. But I'll shift to the part that we're probably more interested in, which is talking about what's hot in MS research. Now, I've sort of put together this little scaling system here, not necessarily about interest levels or importance levels at all. It's more probably about what was the newest in 2022 or the biggest updates in 2022. So we're going to talk about lifestyle modifications, particularly around what was discussed at ECTRIMS. The reason I've got that lower down the scale is that I don't think there was anything particularly new. Some little nuanced things that were coming out that we'll discuss, but no huge updates in that space. Personalized medicine and remyelination. Personalized medicine, I'm just going to touch on a little bit, but I think is an interesting thing that we're going to shift towards. Remyelination is a big one, and we've got some updates on that. But really the biggest one I think that we'll be talking about in terms of the biggest update that we had in 2022 was around Epstein-Barr virus, or EBV. And I've just, almost as a bit of a joke, but just as a little bit of interest put in terms of really what's hot was podcast hosting, which Peter will agree with because he's hosted a number of excellent MS Plus podcasts. But just to make people aware, if you haven't seen, just while we talk about ECTRIMS, I was fortunate enough to host the ECTRIMS podcast this year. So this was the first time that they launched an official conference podcast. And so just to make people aware that this exists as another resource that you may want to subscribe to, we did daily summary podcasts talking to key members of the conference. And there will be a number of other episodes that start to be released across the rest of this year and also into 2023, touching on a number of topics that I'll be touching upon in this. HSCT, we've done a podcast actually interviewing a researcher here from Melbourne, Professor Thomas Kalinchik. We also have an upcoming episode on remyelination, talking to some of the researchers from the University of Cambridge. So it's available on Spotify, Apple Podcasts, just as one that you may be interested in. It's just called the ECTRIMS podcast, an extra little bit of information that you may want to subscribe to get some information there. All right, so as I said, the biggest thing in 2022, I think, was some of the research related to Epstein-Barr virus. And this has probably been a story that's been building for a couple of years, but there were a couple of key publications in January this year that really took this story forward. And so I want to go through, break this down and really try and explain this completely, because again, it was something where there was a lot of misinformation is probably too strong a word, but confused information online when this research came out. So I just want to talk through where we were. So what the research had shown before 2022, where we are now after the publications that we had at the start of this year, and where we are going into the future. So in terms of where we were, I think one of the first things to say about this, and one of the biggest confusions, is just having an understanding of what EBV is. So EBV is Epstein-Barr virus. It's a really common virus that we're exposed to often in adolescence. And it can lead to glandular fever or infectious mononucleosis, depending on what part of the world you're from. Same thing. But importantly, most people who are exposed to EBV never develop any sort of symptoms. So they don't develop glandular fever, they don't have infectious mononucleosis. So as we're sitting here talking about this, and we're talking about how EBV might be involved in MS, It's an important distinction to make. You may not have had glandular fever. That doesn't mean that you haven't been exposed to EBV, and that's really important. And so when I started doing MS research back in 2005, 17 years ago now, that makes me feel really old. It's been a long time. This was sort of how the story was at that time. So we've been talking about EBV for a really long time in terms of multiple sclerosis, but this is kind of what the numbers showed at that time. In people living with multiple sclerosis, it was around about 95% of people seem to have been exposed to EBV, that they'd been previously infected with EBV. But we also knew that around about 90% of the general population had also exposed to EBV. So it was hard at that point to really make any sort of definitive conclusions about a link between EBV and multiple sclerosis, because it obviously wasn't 100% at this point. 100% would have been a more convincing argument. But while it was slightly higher in people living with MS than the general population, it was kind of just high across the board. And so really, while it seemed to be an interesting story at that stage, we were probably just thinking, look, EBV is just a really common virus that people are exposed to. And so most people are exposed to it across their lives. And so it makes sense that most people with multiple sclerosis have also been exposed to it. And the important thing here to note in terms of where we were and how it differs to where we are now is that those numbers, again, were 95% in people living with multiple sclerosis and about 90% in the general population. And the important thing is that it was less than 100%. Okay. But there have been a couple of really key publications that have come out over the past couple of years. And it started actually in 2020. And this was a German study that came out in May of 2020, where they had about 1,000 people living with multiple sclerosis, and they were looking to see, looking to answer a really simple question. In that really large cohort of people living with multiple sclerosis, how many of them had been exposed to EBV? And what they found, using some newer technology that was more sensitive than those ones I was talking about from 17 years ago, they found that it was actually 100% of people living with multiple sclerosis had been exposed to the virus. There wasn't a single person in that study who hadn't or who wasn't EBV positive. Okay, now that changes things. We're now at a point where we're at 100% of people. This starts to become a more interesting argument. This was followed up in January of this year with another really large study coming out of Harvard. And this study, importantly, was looking at US military veterans. Again, it was about 1,000 people living with multiple sclerosis. But the reason why it's important that they were military veterans was it meant that they actually had a series of blood samples throughout these individuals' lives. And so while, again, they looked through this and they found across that 1,000 people, all but one person had been exposed to EBV, and the authors do say that they think there are reasons why that person tested negative, and they think they probably are actually positive. So again, we're basically seeing 100% across a really large study. What this added to that was that they were able to look at some individuals in this group of people who weren't exposed to the virus in their first blood samples. So they actually had blood samples from individuals who hadn't yet become EBV positive. And what they did in those individuals is they started looking across a series of blood tests throughout their lives at two things. They wanted to look firstly to see whether they were EBV positive, and so they wanted to work out at what time points they became exposed to the virus. But at the same time, they looked at something else in the blood called neurofilament light. Now, you don't need to know any specifics about what neurofilament light is, but basically it's a biomarker, a thing that we can measure in the blood. That's a marker of nerve damage. So when nerve damage occurs, when myelin damage occurs, like in multiple sclerosis, we see that the levels of neurofilament light increase in the blood. Okay. And what they could see here is that in these individuals who are EBV negative, when they were EBV negative, there was also no neurofilament light. So there was no nerve damage. And it was only after they had a blood sample where they were then EBV positive, did they then in subsequent blood samples start to see evidence of nerve damage. So this really added to the story. Again, we were seeing a really large cohort of people living with multiple sclerosis that had 100% of people infected with EBV. But also we were seeing that the disease didn't seem to start in these individuals until after they became EBV positive. So in terms of what now we think around EBV, and there are still a number of questions that need to be answered, but our thought process around this is that EBV is necessary, but not sufficient to cause multiple sclerosis. So what we mean by that is, obviously we said 90% of the general population gets infected with EBV. We know that 90% of the general population don't develop multiple sclerosis. So we know that just being infected with EBV alone is not enough to cause multiple sclerosis. It probably interacts with other environmental factors and other genetic factors that we know exist in MS. We don't know how those interactions work exactly yet, but it does seem to be the case that you cannot get multiple sclerosis unless you have been exposed to this virus. And this has been extended upon just a little bit with another paper that came out later in January this year, where they started to give a bit of an idea as to how this might be the case. And essentially what it looks like is a case of mistaken identity. So in terms of how this works in individuals living with multiple sclerosis, what they think might occur and what this paper showed is that when you become infected or exposed to the virus, your body generates an immune response as it normally would when it gets exposed to a virus. However, the cells that get activated to respond to the virus, or some of the cells that get activated to respond to the virus, can also recognize part of the myelin sheath. And this is this protein here called glial cam. Glial cam is a protein that makes up part of that insulating layer that surrounds nerves that we know is what gets damaged and attacked in multiple sclerosis. And so it seems that these cells that get activated to attack the virus can then also attack the myelin sheath. They don't mean to do it. They are just seeing that protein and thinking it's the same as the virus. And that's just because part of this protein looks almost identical to part of the virus. And so it's a case of mistaken identity. And so this has obviously led to a lot of interest. Now, where are we going? What might this actually mean for people living with multiple sclerosis? Well, there's two things. One is that this theoretically could lead to prevention. If we're saying that exposure to this virus is necessary for multiple sclerosis to develop, then hypothetically, it can prevent people from being infected with EBV. We can prevent multiple sclerosis from developing. And so Moderna, who a lot of us would have heard of from the mRNA vaccine that they developed for COVID, are in the process of developing an mRNA vaccine against EBV. It is a long while off. We're not going to see these vaccines develop anywhere near as quickly as we saw them come about for COVID, but they did earlier this year dose their first healthy individual with this, and so they're going through safety trials of that at the moment. So it's a long while off, but it's something to I guess, keep an eye on, with an idea and a hope that potentially we can see a future here where we're able to prevent multiple sclerosis. Now, there are a lot of steps to go through in that process. We don't know exactly, at what time point we will need to dose people with this vaccine for it to be effective. We don't know, whether or not we'll be able to prevent it enough to stop MS from developing. But, theoretically, there is a possibility there. Now, for people who are already living with multiple sclerosis, obviously that's not that useful. But EBV is also being investigated as a potential therapeutic target. So Atara Biotherapeutics in the US, and also some researchers here predominantly along the east coast of Australia, being led by Professor Michael Pender from Queensland, are currently conducting early stage clinical trials of a therapy designed to target EBV. So EBV, just to give a little bit of extra information about it, is a chronic infection. So unlike other infections that you may get where your body comes into contact with the virus or the bacteria, you may feel a little bit sick, but then your immune system clears that completely. EBV is never completely cleared from the body. It tends to be a chronic infection, hangs out in some interesting places related to multiple sclerosis, tends to hang out around the central nervous system, and also in B cells. So part of the reason now why people think that therapies that deplete B cells, such as ocrelizumab, may have part of their benefits is through depleting cells that contain EBV. but it tends to hang around. And so what these clinical trials are looking at is what happens if we can clear EBV from the bodies of people living with multiple sclerosis. And so there are ways of doing that, basically where they take T cells, immune cells that are specifically designed to target virally infected cells, activate them in a lab so that they're really souped up essentially to target EBV, and then inject them into people living with multiple sclerosis. And they've seen in really, really small early stage trials that not only can this be effective, but it can also have some clinical benefits for people living with multiple sclerosis, improved mobility, improvements in fatigue. Now, they're very small early stage trials. We're waiting for the phase 2 results to come out. I'm hopeful that we might see them by the middle of next year, but some interesting things there. And I guess the really important part about that therapy is a different sort of approach, is that it's specifically targeting something that we know could cause some problems in multiple sclerosis, which is different to other therapies we have at the moment, which are just around dampening or changing the immune response. So this is a more targeted therapy, which hopefully would come with less side effects. So that's the EBV story. I've given a lot of information there. Before I move on to anything else, were there any questions around EBV that we can address at this point?
Yes, we have a couple of questions that have come in. So in relation to EBV, can EBV be cleared from the body through HSCT? And if so, could a person be cleared of MS returning, so to speak?
Good question. I don't think anyone's really looked at whether or not EBV gets completely cleared through HSCT. So HSCT, which I'm going to talk about a little bit later, but HSCT has that initial phase where basically a high dose chemotherapy wipes out the existing immune system, based on the fact that EBV can reside in B cells. Theoretically, you may get some EBV clearance as part of that. HSCT as a therapy certainly has shown the ability to provide really long-term benefits to some people living with multiple sclerosis, but no one's looked to see whether or not that's linked to EBV or how EBV plays a part in that. It's a good thought, but yeah, we don't know that. I would be surprised if it led to complete clearance through HSCT. It may certainly lead to a lower amount, but yeah, and whether or not that would then also lead to complete recovery from multiple sclerosis. I think we need to be careful when we think about that with HSCT, just because of the way that we repopulate the immune system at the moment. Going off track slightly, but we use AHSCT in multiple sclerosis at the moment. The A in that stands for autologous, and what that means is that we're wiping out the immune system of an individual, but before we do that, we're taking out some bone marrow from that person, and then we repopulate that in. So it's the same immune cells that are going back in. We're not getting it from a healthy donor or anything like that. And so while we've seen long-term benefits, the reason why I'm very hesitant of ever using the word cure in multiple sclerosis as things stand, but because they are the same cells that are going back in, theoretically, you know, they are, while they've gone back in at a stage where they haven't yet learned to attack the myelin, they could still have those same triggers, whether that's being exposed to EBV again, which is certainly possible, or other environmental triggers. You know, it could happen again. So yeah, great question. But I think there's still more work to be done in that space to understand how they might link together.
I'm sure another one here that I'll quickly ask. In relation to B and T cells, there was a UK professor heavily involved in UK trials that said that someone's MS is either B cell driven or T cell driven. He said that MS that is B cell driven is more aggressive. Did you know about that, and what are your thoughts?
It's a good question. I think for a long time, certainly back when I started doing research, we thought about MS as being a purely T cell driven disease. I think we know that's not the case now. I haven't heard anyone specifically talking, I don't know, it would be good to have a name on this. I don't know if it's Gavin Giovannoni, who talks a lot about things in this space, if they know, but I haven't heard about specific individuals either being B cell or T cell. Generally what we know, and there was some really exciting work that came out from Roland Martin's group from Zurich, who looked at this, and what they found was that B cells play a really important role in terms of communicating with the T cells. And so they play an important role in helping to that T cell response that we know occurs. B cells play a really important role in kick-starting that, which we hadn't really appreciated before that time. So my general thinking at the moment, and again, there is about 4,500 papers published on multiple sclerosis every year. So there's certainly things that I miss, and I'm happy to read more into this if people want to share through links or stories around it. My thinking is that they tend to work together. And so, part of the reason why B cell therapies can be effective is if we know that the B cells are important in helping to kickstart that T cell response. Getting rid of the B cells means that then the T cells also don't go around attacking things. So I think often they work together, but I'm interested to hear these thoughts around specific individuals being B cell or T cell, because certainly then, if that was the case, it could lead to more personalized treatment approaches. Obviously, if you had someone who had a B cell driven disease, then it would be looking more to give them a B cell therapy like ocrelizumab. Whereas if it was a T cell driven disease, although as I said, B cells tend to be important in that stage as well, you may look at some of the other ones that may be more effective at stopping the T cell response. But yeah, interesting question. I haven't seen that person talking about it. All right. So if any extra questions come through on EBV, happy to answer them again at a later date. But I'll move on to the next little bit, just keeping an eye on the time. This is not really research, though there was research behind it, but I just wanted to highlight now, I'm really shifting into, while EBV was talked about at ECTRIMS, it was really the big story. This is now really focusing on what we heard at ECTRIMS, and I just wanted to make mention of the fact that there was a session at ECTRIMS. People probably do know, but ECTRIMS is the European Committee for the Treatment and Research into Multiple Sclerosis. It's the largest MS research conference in the world. It tends to be around 9,000 to 10,000 people who attend, clinicians and researchers from around the world. And there was a session at this year's meeting in Amsterdam focused completely on the role of multiple sclerosis nurses. And I think excitingly, and something that we can be proud of here in Australia, is that it was, the 3 presentations, 2 were given by people from Australia. Therese Burke, who a lot of people might know through a role at MS Australia, and also Belinda Bardsley, who's based at Austin Health here in Melbourne. But really talking about the important role that MS nurses play, and I think we're ahead of the curve here in Australia in terms of this. And the MS Nurses report came out earlier this year that was obviously something that MS Australia was heavily involved in, showing the benefits that people derive from having access to an MS nurse, and also seeing, providing some data around the accessibility, and for people who didn't have access, why didn't they have access? So really important things being discussed, but I think it's exciting to know that at such a global stage, we're having such a big impact. So I just wanted to feature that slightly. All right, so lifestyle modifications, I put this down the lower end of my list in terms of how hot it was, but purely I think that was based on the updates. And I think we can think about this in a couple of ways. We could take that glass half full approach that goes, well, that's disappointing that we haven't learned more about what's going on. But I think for me, the 2 things that I took away from that using my glass half full approach, sorry, I don't know if I just said glass half empty or glass half full before. The first one was glass half empty. This is glass half full. Is that, one, there's a real commitment from the conference organizers to ensure that we're talking about lifestyle modifications at every meeting. And so this has been into the agenda, and that may mean that we're hearing about things that haven't really progressed hugely over the past 12 months. But regardless of that, there's an understanding that this is a topic that people living with MS feel really passionately about and that we need to be talking about as a research community. That's one thing. I think the second thing to do with it is the fact that it probably means that we've made a lot of progress in this area as well. So, you know, we've taken a lot of steps forward in terms of this, and so the next steps might take a little bit longer. So these were the 4 key ones that I talked about. Probably heard about them a lot before. Exercise, I think there's a general understanding now and a general consensus that exercise forms a really important part of the management of multiple sclerosis. Guidelines have been published on this by the US National MS Society, taking research from a number of exercise physicians around the country, specifically for people living with multiple sclerosis. I also think there was an understanding, a lot of discussion around the fact that obviously we need to be really conscious of the fact that exercise is going to look very different for different people living with multiple sclerosis. We don't have a one-size-fits-all approach to this, and this is going to be a really common part as we talk about lifestyle modifications, but we need to be very aware that what works for some people isn't going to work for others, but that there should be a way that we can find exercise programs that work for everyone. I think the one key message that came out of it that I found particularly interesting was that for a long time there's been a thought of using exercise for rehabilitation. So as mobility starts to get lost, as strength starts to get lost in people living with multiple sclerosis, exercise is then added to try and restore the function that's being lost. Whereas what's being decided or discussed now is that really we should be doing prehabilitation instead of rehabilitation. And what that essentially means is that there's a feeling that exercise should be being incorporated at diagnosis, that we shouldn't be waiting until function is being lost. We should be trying to preserve function for as long as possible and using exercise to do that. Smoking, I think, is one of the ones that we've seen a lot of progress over the past couple of years, and one of the lifestyle factors that we know has a serious impact on multiple sclerosis. There is really, really strong evidence now that shows that not only does smoking increase the susceptibility of an individual to develop multiple sclerosis, but it also worsens progression. I think the important message to come out of this is that it doesn't matter how long a person has been smoking for, quitting at any time does have benefits to their outcomes in multiple sclerosis. So quitting at any time does slow the progression of the disease, or compared to continuing to smoke. Anyway, so I guess for when we have these conversations, people have been doing it for a long time. There's no point quitting now. The research shows that there definitely is. I think the interesting thing around this as well, and one of the things that came out a lot around lifestyle factors, is that there's an understanding that we need to have programs tailored specifically for people living with multiple sclerosis. So one of the things that was being discussed at the conference is developing some programs around how to quit smoking for people living with multiple sclerosis. We obviously have programs like Quit in Australia that are designed to help people in the general population, but there's an understanding that there will be some specific considerations for a person living with multiple sclerosis that may not necessarily affect someone else. And so we need to come up with some specific programs to help with that, to help people quit smoking if they are indeed continuing to smoke after being diagnosed with multiple sclerosis. Diet is one of the big ones that we know people is interested in. Probably the key message out of the conference was that as of now, the research hasn't showed, and there is no evidence to suggest that there is one MS diet that is better than any others for every person living with multiple sclerosis. There are obviously a number of different diets that are being investigated, but as of now, the researchers don't believe that there is anything there to suggest that one is superior over the others for every person. I think there is an understanding, again, that dietary modifications are certainly something that we need to be using in the management of multiple sclerosis, but again, a one-size-fits-all approach won't work, and so it's working out the diets that may be best for each individual. And talking through that and taking a scientific approach to how we go about working out what that might be for each person. And then lastly, sleep. We've seen some interesting stuff coming out of Australia on this as well, done by the Menzies Institute down in Tasmania. But I think the important outcomes in terms of sleep that were discussed at the meeting One, that there is certainly evidence to suggest that sleep quality is lower in people living with multiple sclerosis than the general population. But importantly, that sleep is independently associated with fatigue in multiple sclerosis. And I think what that means is that for a long time, we may have had an understanding that sleep, or people living with multiple sclerosis didn't sleep particularly well, and there are a lot of reasons for that. But when a person talked about sleep and talked about being tired or being fatigued, there was often just an idea of, well, yeah, you've got multiple sclerosis, of course you're fatigued. It's a really common part of it. Understanding that the impact that sleep has on this is just separate to the normal fatigue that's experienced as part of being living with multiple sclerosis. Sleep is something that can be targeted. There are ways that sleep quality can be improved, and so looking at sleep as a factor that can then improve fatigue in people living with multiple sclerosis is something that I think we're going to see more of. I would expect to see some study results on that presented at ECTRIMS next year. So that's lifestyle modifications. We're going to move on to remyelination. I don't know if there's any questions on that to cover off before we move on to remyelination, which may be the last topic that I talk about based on time.
Just a quick question about vaping. Is there any data out on vaping and MS?
So I haven't seen anything specifically on vaping and MS. I wouldn't be surprised. I would be surprised actually if we had enough data on that yet to publish anything meaningful. I wouldn't be surprised if there were similar outcomes based on it, but that's just a hypothesis. Yeah, we don't have any data that I've seen yet on it. Something to keep an eye on, but yeah, I haven't seen anything on that yet. Certainly nothing that was presented at the conference. All right, well, I'll move on to remyelination, and in the interest of time, I might have this as our last research topic that we talk about. There's some other ones at the end that I'm happy to answer questions on. There was progressive MS, personalized medicine, HSCT, biomarkers. There was a few things in there that I'm happy to talk about questions at the end, but I'll save this as the last part of the sort of presentation. So remyelination is obviously a really hot topic in multiple sclerosis at the moment. As I said, we've got a podcast episode coming out from the ECTRIMS podcast, talking to some people from the University of Cambridge around a clinical trial that's underway there around this. We also have a video with them coming out on MStranslate along the similar lines. But I think reason why remyelination is really important is that what we're talking about here is repairing the damage that's caused to the myelin sheath in multiple sclerosis. While we've made a number of advances in terms of treatments, all of those treatments really are designed to dampen down the immune response or alter the immune response to stop new damage from occurring. None of those therapies are designed to repair any existing damage. And this is really the biggest unmet need in multiple sclerosis. What we do know is that myelin repair is possible, and it is actually quite common. If we look outside of multiple sclerosis, if you get a concussion, if you get a viral infection around your nervous system, myelin damage can occur there. It's just that in these instances, that myelin gets repaired really easily. Even in people living with multiple sclerosis, really early in that disease course, myelin repair can occur. But what seems to happen is that that ability to repair myelin in people living with multiple sclerosis decreases over time. In terms of remyelination research, then, there are a lot of different avenues that are being explored. I think that's one of the key messages around this. We have some understanding around the pathways that are involved in the remyelination process, in the myelin repair process. We have some ideas around where the blocks in that process may be. And so people are really investigating each of those specific blocks to see whether or not they can be overcome. The good thing about that is obviously the more avenues that we explore, the more likely that we are to, one, get something that's successful. And if we get multiple things that are successful coming from different approaches, that will hopefully mean that we'll have things that may be effective in a greater number of people living with multiple sclerosis. In the same way as we see with our current existing therapies, we know that we have a lot of different options. We know that not every option works for each person. The same thing may be true in remyelination. So the fact that we're coming at this from a number of different angles is really important. But I just want to focus on one because it leads to I think, probably the most exciting clinical trial that's going on at the moment in this space. So this is a little diagram, and again, you don't need to worry too much about the specifics. I'm going to talk through it, but this is a diagram out of an early paper that came out of the University of Cambridge work, which is what I'm going to talk about here. So just to focus on the bottom part of this at the moment. So these cells here, we have two types of cells here. We have OPCs, which you may have heard of before. That stands for oligodendrocyte precursor cell. Basically, that's just a baby cell that then turns into this cell here called an oligodendrocyte. And the reason why we're interested in oligodendrocytes is that these are the cells that make myelin. So in terms of being able to repair myelin, we're interested in these oligodendrocytes. We need them to be around. And so we need OPCs to be able to grow up into oligodendrocytes for that to occur. And so one of the things that they're looking at, and one of the things that seems to happen, is that when these cells are young, they do this really well. They turn into oligodendrocytes. Those oligodendrocytes are able to repair the myelin. However, during the aging process, and so when we see people go further into their disease course and multiple sclerosis, these older OPCs are really bad at turning into oligodendrocytes. And if they can't turn into oligodendrocytes, they can't make that myelin. And so what the University of Cambridge are looking at is how do we actually go about slowing this aging process? How do we slow this aging process so that this repair process can work more efficiently? And so one of the ways that we know is one of the best at slowing or reversing the effects of aging is fasting. And so what they did originally was that they looked at in an animal model of multiple sclerosis, so a model that we call experimental autoimmune encephalomyelitis. I don't know why I waited until I'd been talking for about 50 minutes to chuck in all of the big words and hope that I could say them properly, but so far so good. So in EAE, which we call it, in this animal model of multiple sclerosis, they took two groups of mice. And in the first group, what they did was they did an intermittent fasting approach. So they had mice that only ate every second day. So they had a day of eating, then they had a day where they ate nothing, and then the next day they would eat again. They compared those mice to mice that just ate normally and could eat whenever they wanted. And what they found is in the mice that had that intermittent fasting, so only eating every second day, they found that those mice were able to repair the myelin that we're getting because they had this animal model of multiple sclerosis and their myelin was getting damaged, but they were able to remyelinate better than the mice that were eating all of the time. Now, what they wanted to do was they also wanted to test a drug called metformin. Now, metformin is a drug that's used quite commonly in people living with diabetes, and it essentially mimics that process of fasting. And what they found doing exactly the same experiment, mice that got metformin versus mice that didn't get metformin, again, they could see in those mice that had metformin, they similarly had improved myelin repair. In a completely separate study, they've also seen that calorie restriction, so a slightly different approach to alternate day fasting, but calorie restriction also lead to improved myelin repair. And so the reason why, slipping to the next topic. The reason why this is important, why these mouse studies are important, is that this has now led to a clinical trial at the University of Cambridge. They're about halfway recruited at the moment in terms of their total numbers, and they're going to be looking at metformin. Now, we specifically asked them when they called up, why did you choose to look at metformin, not intermittent fasting? And that was based on interviews with a group of people living with multiple sclerosis that they had at the University of Cambridge. And they said that they thought it would be difficult for them to follow the intermittent fasting protocol. So they've decided to start with looking at metformin because there are some concerns around intermittent fasting in people who are already fatigued, already have lower energy levels. So they want to start by looking at metformin. Interestingly, they are planning on doing a follow-up trial where they will be looking at intermittent fasting as well. So they do want to look at that approach as well to see how it can impact on myelin repair. And so they're currently looking at metformin in combination with another drug called clemastine, which is actually part of over-the-counter antihistamines that was identified through some screening studies done at the University of San Francisco. So this is going to be really interesting to see these trial results, to see if we can get some drugs that are successful in repairing myelin in people living with multiple sclerosis. It's an early stage trial. We should get some of the results by probably 2024, but maybe some updates next year. We'll certainly be following them up on that. So there's a lot of exciting things happening in the space of remyelination as well. Considering the time, I'm going to skip through all of this stuff, but thank you for listening. Happy to take any questions. I think the key message is that in 2022, there's a lot happening in the world of MS research to be excited about. Really interested to see how a lot of these stories are going to develop, especially in the remyelination and EBV space in 2023. And beyond the webinar itself, if you have any questions, my email address is there and feel free to reach out. Thank you.
Great. I might just get to a couple of the questions, Brett, and then potentially if I can, any questions we don't get to, maybe email those to you, and you can just write a short response if that's okay, and I can send that out to the attendees.
Yeah, go for it. Great. Yep, that's fine. Shall I stop showing my screen? We don't need that up anymore.
Oh yes, perfect.
That's
so I'll just run through a few questions, and sorry that we're running a little bit late, everyone. So if you need to go, please do, but we'll probably just ask a couple of questions and finish maybe 5 to 10 minutes late. So I've got a question here. What do you think is the next big thing in MS, and how many years away?
So I think it's definitely going to be remyelination. I mean, I think the EBV story will be interesting. I think it's more interesting in terms of being able to potentially prevent MS in the future. For people currently living with multiple sclerosis, it's going to be remyelination. I think it's the next big step. I think now we're at a point where we have a lot of options for trying to slow that disease process. And, you know, I think HSCT could be an interesting option that may enter into that as well. But I think if we can complement those therapies with having a therapy that can actually repair the damage and repair damage to myelin, that's where we start to look at sort of complete management of the disease and actually starting to be able to reverse some of the symptoms. So I think that's the next big thing in terms of timeframes. We do discuss this on the ECTRIMS podcast with the researchers from Cambridge, 10-ish years. Now I'm hopeful that, you know, that's for something being on the market. It will mean that we'll have clinical trials obviously before that. And I'm hopeful, you know, we may start to see some phase 3 clinical trials for this within the next 5 years, would be my hope in that space.
Great. And this question is in relation to, I'm not sure if I'm saying this right, but cytokine or cytokine release. So when stressed or upset, is there a way to prevent the release
of cytokines? So cytokines are they're chemical messengers of the immune system. So they tend to be released commonly in response to some sort of infection. So when the immune system is ramping up, cytokines get released to help activate other parts of the immune system, or as it's ramping down, different cytokines can be released to tell the immune system to back off. In terms of being able to take things to prevent cytokine release, nothing that's really just as something to take during stress, if that was the specific situation that I'm aware of, to prevent cytokine release during that time. Obviously, there are a lot of lifestyle modifications that can be used to decrease stress, and I know MS Plus has had Dr. Sally Shaw on before, and she talks a lot about this and ways to manage stress, because yes, stress can certainly be something that can impact on disease progression. In terms of cytokine release, I mean, a lot of the immunomodulatory therapies that we currently have for multiple sclerosis probably do have some impact on cytokine release. I mean, if you're depleting B cells, it's going to have an impact on cytokine release. But yeah, nothing specifically that I know of in terms of something to take during stressful times to look at cytokines.
Can HSCT alter microglia, or will it only impact the B and T cells and therefore not help stop the smouldering disease?
Good question. I mean, primarily it's going to be looking at B and T cells. I mean, in terms of the smouldering disease, it's a really interesting area that I think we still need to know more about. But I think probably I can answer this a bit more broadly in terms of what we've seen with HSCT in terms of who is most likely to benefit, because I think it sort of ties into that question. So I think in terms of HSCT, what a lot of studies now have shown is that the people who are probably most likely to benefit from it. Now, this is not to say that they are the only people, but just in terms of a best guess as to who would benefit from it, are people who are quite early in their disease course and who have highly inflammatory disease activity. So these are people who tend to have, very aggressive disease soon after diagnosis, have probably failed. I mean, in terms of getting access to it at the moment, have probably failed one or two highly effective therapies before moving to HSCT. And the likelihood of that in terms of how it ties into things is really, it's probably that inflammatory activity that we're targeting with HSCT, as we are with lots of other drugs, to be honest. It's just a more powerful way of a thorough approach of doing it, essentially. And so in terms of smouldering disease, yeah, difficult to say. I haven't seen anything that specifically looked at the disease mechanisms around smouldering MS, smouldering disease in terms of HSCT. But it's more likely that it's going to be beneficial in people with highly inflammatory rather than neurodegenerative. And so we think, again, we can't apply a one-size-fits-all approach to this, but as a general thing, people would say that HSCT is mostly effective in people with relapsing remitting MS rather than in progressive MS. There is a push to get rid of those titles altogether at the moment, but probably largely because what's driving the disease in relapsing remitting is inflammation, whereas in progressive, it's more degeneration that's going on. So yeah, I don't know if that's quite answered the question, but yeah, I think still more to be seen in that space. But I think what we're starting to see now, and some of the stuff I didn't talk about, is that studies are now starting to look at how HSCT directly compares with other therapies to see where it might fit in. So there was some really exciting work done here in Melbourne looking at how, that was part of a big collaboration, international collaboration, but led by Melbourne, looking at how the outcomes from HSCT, in particular relapse rate, compare with HSCT compared to fingolimod, compared to natalizumab, Gilenya, Tysabri, and Ocrevus. So I think there's more to learn in that space as to how it all fits in, but yeah, that's sort of the general thinking at the moment.
I might just finish with one more question. And yeah, I apologize if we haven't got to your question today. As I said, we'll send out the answers to any questions that we didn't get to. So just one on intermittent fasting. Can the 16 to 8 fasting work as well as the 1 day on, 1 day off?
Good question. I don't think we have an answer to that yet. I mean, the 1 day on, 1 day off was just the protocol that was used in that University of Cambridge study in the animal model. I don't think we have strong evidence, certainly in terms of remyelination anyway. I don't think there's been any large, well-controlled studies looking at this in people living with MS. There certainly has been some small studies that have started to look into it, but in terms of different fasting protocols and how effective they may be in terms of myelin repair, we don't have that data yet to be able to answer that.
Okay, thank you very much. I might just now finish off. So that should be showing my screen now. So just a few slides to finish off, and thank you very much, Brett. That was a very informative presentation. So we do have a number of services here at MS Plus. If you aren't aware of the services we have, or you haven't used any of the services before, before, then this slide's great. It outlines all the services that we do offer. So we offer a range of emotional and practical support. Please call if you do think you can benefit from any help or support. Please do call us here at Plus Connect, and we can then refer you to any of these services. I'll go on to the next resources. Again, we do have a number of resources. We conduct webinars normally monthly, sometimes a couple per month, and they are all recorded and put up on our resource hub, which is pictured there. You can access that via our website. We also do podcasts. We haven't been doing that many of late, but we are going to ramp that up soon. So keep an eye out for those, and there are a lot of podcasts that are in our library. So please go have a look, and you can access that through Apple Podcasts, Spotify, or a number of other. If you use other podcast streaming services, then have a look, because it's probably available. We also do articles, and we have an In Touch newsletter. So if you aren't receiving that newsletter, please reach out to us, because that is very handy to have. So as I was saying before, calling Plus Connect is your go-to sort of conduit between all the services we offer here. So please do call that number on screen, 1-800-042-138, or email at connect@msplus.org.au. They are very helpful, so please give them a call. I think today's presentation was amazing, very informative, and I think it really shows that we are coming a long way in research and medicine. So thank you to Brett, who was kind enough to come today and give an update on that, and very excited to see where we progress in the future. So thank you, Brett, and thank you all for coming.
Thanks, everyone.